Um, Good morning. Um, it's nice to see you all here. I'm Sarah Weatherson, lead staff for the Medicaid Advisory Committee, she, her pronouns. And thanks for being here. I'll just open up with a few reminders, reminding you to mute yourself if you're not speaking. If you're on the phone and you need to leave for whatever reason, it's better to just hang up and rejoin the meeting later. Hold will give us lovely hold music, which is hard to hear over. We'll ask folks to choose either the English or the Spanish channel in Zoom for interpretation. That way, if we have dialogue back and forth with questions, you'll be able to hear the translations. And then with that, I'm going to hand this meeting over to Heather Jeffress to introduce our speaker and topic.
Thank you, Sarah. Hello, my name is Heather Jeffress. I am the co-chair of the Medicaid Advisory Committee, and I wanted to welcome you all today. Good morning. I need some more coffee. Welcome you all today to our educational session hosted by the Medicaid Advisory Committee. This session is to help Oregonians understand Medicaid's place in our health system. And we are so pleased because we have no better person to do that than our Medicaid director, Emma Sando. And so with a big thank you, I want to welcome her today to give us an excellent presentation that we've all been looking forward to. So good morning, Emma.
Morning, and thank you so much for having me and for everyone that's taking the time out of their day to join this. For folks that have seen me testify in my Medicaid 101 uh, briefing to the legislature, which I did a number of times last year, a lot of this content will feel familiar. And then for the very small number of you that have taken my university classes on Medicaid 101, a lot of this content will also feel familiar as a little bit of a background on who I am. I used to be a professor and really enjoyed teaching people about Medicaid, and so I'm excited that this job as Medicaid director, which is not usually talking about what Medicaid is and isn't, allows me some opportunities to do what I love, which is to tell people all about what the wonderful things are that Medicaid does and what Medicaid is. So without further ado, let's go to the next slide. So first question, what is Medicaid and what is the Oregon Health Plan? Next slide. So Medicaid is a joint federal and state program that is run by the states. So essentially what the federal government does is lays out rules for what all states need to do in order to receive funds from the federal government. These are broad and flexible rules, but also can be pretty specific from time to time of saying what CMS, the federal government, the Centers for Medicare and Medicaid Services, allows and what they don't allow states to do in order to spend federal funds on the Medicaid program. Oh, there are ways in which states can change those rules. One of those ways is through a waiver of the Medicaid rules. But for the vast majority of what we do is follow the broad federal guidelines, but then when there's flexibility, make it specific to the Medicaid program within our state. Every state now has a Medicaid program. Fun fact, Medicaid was started in 1965 as part of the Lyndon Johnson War on Poverty. And all states, with the exception of Arizona, implemented their Medicaid programs within the first couple of years after that began. Arizona waited out until 1982 when they could have what is known as managed care as part of their Medicaid program. So we call our Medicaid program in Oregon the Oregon Health Plan. Every state has a different name for their Medicaid program. Some just call it North Carolina Medicaid or Alabama Medicaid. Others have sort of fun names for their program. Wisconsin is Badger Care. Our neighbors to the north in Washington now call it Apple Health. They had called it Apple Care, but that got very confusing when people were bringing in their laptops. So make it very clear that it's not the same as the computer company. So ours is Oregon Health Plan, which is very straightforward in terms of saying what the state is and what it does. Most people that qualify for Medicaid or OHP qualify based on income. So that a person that has an income of less than 138% of poverty, no matter if they are a child or an adult under the age of 64, generally qualify for Medicaid based on that income. And when I say a children's income, we know that children aren't usually having their own income. A 17-year-old might have a job, a summer job or something like that, but most children qualify based on their parents' income, their household income, and the same applies for a parent or an adult qualifying for Medicaid is based on their household income. There are also a number of programs that are based both on your income and your health status. And that's actually what Medicaid started out as, is you had to qualify not only based on having a low income, but you also had to have a health status that met certain criteria. So an example of that health status might be pregnancy, for instance. If you're pregnant and you qualify for Medicaid at a certain level of income that is different from the what I mentioned earlier. Another is having a disability or being over the age of 65, as I mentioned earlier. So these programs are a little bit more specialized because they often will provide additional services such as long-term services and supports or personal care needs to assist people with their activities of daily living, particularly for people that are have those needs for additional services for activities of daily living. Medicaid also wraps around people that are enrolled in Medicare, either enrolled in Medicare due to their age or disability, because Medicare, interestingly enough, people think of it as an extremely generous benefit. And yes, it does cover a lot of things, but oftentimes people on Medicare have a lot of co-payments, cost sharing, deductibles. There's really no limit on the amount of some of those co-payments, deductibles, and other costs that can be associated with Medicare. And so Medicaid helps pay for some of those costs for certain Medicare members. Next slide. I find the difference between Medicare and Medicaid very interesting, and I will note there's a large percentage of people in our country that qualify for both. So they are both enrolled in Medicare and Medicaid. But the general way in which we can talk about the difference between Medicare and Medicaid is that Medicare is funded through a trust fund that people that are working pay through their payroll taxes. So if you look at your W-2 or other statements, you'll see that certain amount of money was set aside for income tax, a certain amount of money was set aside for Social Security, and a certain amount of money was set aside for Medicare. There's also people pay for Medicare through through a variety of different um, other payments like co-payments and premiums for certain other services. Meanwhile, Medicaid is paid in, and we'll get into this in a little bit more detail, in part by the federal government, but then also the state pays a portion of that through either state or local taxes. So the federal government pays a portion through their funding through income taxes or other ways in which the federal government gets money, and then the state pays for their portion through a variety of different methods, including state and local taxes. Medicare is the same program no matter where you live. You can move from state to state, and you'll generally get the same services at the same cost. There is a little bit of variation for high cost places. They know that being a primary care doctor in the middle of Wyoming costs a little bit less than being a primary care doctor in Manhattan. So there's a little bit of a difference in how things are reimbursed, but overall it's generally the same. Meanwhile, the Medicaid program in Oregon looks extremely different from the Medicaid program in Idaho based on who is covered, what sort of services you can get. So when you move through the Medicaid program, your experience is going to vary very differently depending on which state you live in. Benefits in Medicare are for people that are over the age of 65 or have disabilities. Generally for Medicaid, it's for people with very low incomes. I mentioned earlier in Medicare, there's deductibles and other parts in which you have payments as an individual, but in Medicaid, we don't have those co-payments and premiums and deductibles. So when you get services, it's free to the member right now. There in Medicare, you have your hospital coverage, your primary care coverage. You might have a managed care plan that does both hospital and those other primary care services, and other doctor's office and other provider services. And then you have a drug plan as well. So those are the different types of benefits in those services. What I didn't say in those services are things like dental and vision and getting to and from the appointment. Those are covered by Medicaid, but those are not covered by Medicare. So when somebody has both, that often can be people with disabilities or people that are older, they can qualify for both oftentimes, depending on their income. And they also have that prescription drug coverage, those additional services in the outpatient setting, as well as in the inpatient setting. Next slide. So inside and outside the hospital. So in 2023, Oregon achieved the most people covered by health insurance in our state's history, and the second most in the country. Although I will quibble with my friends in Massachusetts, and then if any of you are calling from Massachusetts, I'm happy to connect offline. We're just within a couple tenths of a percentage behind Massachusetts, and I'm happy to get into the details, and maybe we're doing really well in comparison to Massachusetts, but Massachusetts has the most people enrolled in healthcare coverage as of the latest statistics, and we're just behind them in terms of how many people are covered. And Medicaid has a lot to do with that. Prior to the Affordable Care Act, in Oregon, we had 14% of the population having no insurance whatsoever. And so the expansion of Medicaid to cover people that are adults that don't meet one of those categories of disability or pregnancy or whatnot, meant that more people could get health insurance coverage. The insurance marketplace also made it more affordable to purchase health insurance if you have additional resources and are able to purchase health insurance. We also did a number of things in order to keep people covered during and after the pandemic, that a lot of states were removing people from coverage who may still be eligible, but Oregon worked really hard to find those folks and keep those folks covered as much as possible. Next slide. So where do people get their coverage? Most people, 4 in 10 people, get their health insurance through either an employer or a group plan through veterans programs or student health plans, but most is through employer-sponsored insurance. 3 in 10 people have Oregon Health Plan or OHP, and 1 in 10 have Medicare. I'll note that sometimes people have Medicare and Medicaid, or Medicare and private insurance, and so we tell people to put the non-Medicare first, if they have Medicare, and so that looks lower than it actually is. About 20% of folks in Oregon have Medicare, so about 6% of those folks have Medicare and something else. Or 6% of the population have Medicare and something else. And then another 5% bought health coverage either directly through an insurance company or on the health insurance marketplace. Next slide. So a little bit about who we serve in OHP and in Medicaid. There are 1.4 million people in OHP. This is about a third of the state, as I mentioned in the last slide. More than half of all children are covered by OHP. This is as a result of when people are having children, they tend to be at lower income points in their lives, and I'm sure I'm not surprising anyone. Children are a little bit expensive, and so we do have a fair amount of people that have children that are at or near the poverty level in our state. More than 40% of all births are covered by OHP. So when again, that shows that when people are giving birth, they tend to be at lower income points in their lives as well. We do have quite a diverse set of folks that are enrolled in our program, with 144 total written languages and 242 unique spoken languages. And we know that statistic because we at OHP strive to provide information to people in the language of their choice, and strive to get that language and that information to them in that as well. All materials are provided in the most common languages, and we are able to create materials for some of those less common and unique languages. Next slide. So when we talk about OHP, you can also think of it as we're talking about 3 different programs. One is the Oregon Health Plan. This is our Medicaid program. It covers doctor visits, hospital care, behavioral health services, dental care, prescriptions, transportation, health-related social needs. These are things that are outside of the 4 walls of the healthcare system. We cover a lot of pregnancy and postpartum coverage, and within that there are really 2 different programs. One is our portion of the program that is funded by the federal government, and then the federal government has requirements that that people need to meet certain very high immigration requirements. For example, a person with a green card needs to be in the country for over 5 years in order for the federal government to reimburse the state for their services, except for emergency department services. And so Oregon set up a separate program called the Healthier Oregon Program, which provides the same set of benefits as the federally funded Medicaid program, but for people that would qualify for Medicaid, except for their immigration status. Um, and that is the overall set of benefits and services that are under that program. We also have a new benefit that was recently launched last year called OHP Bridge, which is the basic health program. It's for people with even higher incomes than, oops, we lost this. There we go. Thank you, Tom. So this is for a higher income folks that are 19 to 64. So they may make over 138% of the federal poverty level, up to 200% of the federal poverty level. And it's the same general benefits, except it doesn't provide certain long-term services and supports or health-related social needs. So that some of those extra services aren't provided, but the same medical services are provided. Next slide. So the Medicare Savings Program is a program that helps pay for the Medicare costs. As I mentioned earlier, there are quite a bit of costs in Medicare, so a person may be a qualified Medicare beneficiary, and Medicaid will pay for premiums and other out-of-pocket expenditures, and but it doesn't have some of those extra dental and transportation that are not covered by Medicare. A person may only qualify for the premiums only, and this all depends on a person's income status. And then a person may be a full Medicaid member and get all those additional services and their Medicare premiums and cost sharing paid for. Generally, Medicare pays first. So if you go to the hospital, you get a service and it's covered by Medicare, Medicare will pay the portion, and then Medicaid will wrap around anything that wasn't paid for by Medicare. Next slide. So how we deliver care in OHP. Most people get their care through what are known as coordinated care organizations. And this provides services through a network of healthcare services, or a network of providers, and the coordinated care organizations manage the person's care. 93% of all OHP members are enrolled within CCS. The rest of the OHP members are enrolled in what is known as open card. So this is often called fee for service, and it exists outside of the CCO structure, in part because certain populations are required to be exempt from CCOs or managed care organizations. Some of the populations that this applies to are people that have another type of insurance, whether that be Medicare or private insurance, and Medicaid is only paying for the things that aren't covered by those insurance companies. People that are American Indian, Alaska Native are also have the choice between enrolling in a CCO or paying for fee for service. There are people that are approved for OHP coverage, but they continue to get their care through open card while they are selecting a CCO, and youth involved in child welfare, youth served by Oregon Youth Authority. And if somebody walks into the hospital expecting or delivering a baby, we're not going to wait for them to get care through a CCO. The open card will pay for that, and then they'll get enrolled in a CCO after the end of that health need. And then certain children with complex medical needs. So folks may be enrolled in a CCO for certain services and then get open card services for other things such as behavioral health care services, home and community-based services, and other things like that. Next slide. So what are CCOs? CCOs are coordinated care organizations, are also known as managed care organizations, that are community governed, which means that they have links to the community organizations and community boards. They receive a regular monthly payment for sort of a what is known as a global budget or capitated payment for the cost of each member, and then they work within that monthly fixed payments to coordinate a person's care, and there are rewards given to CCOs that are able to do so effectively and are able to provide high quality care at low cost. And it's designed to improve members' care and ensure that we're being flexible and people are receiving the care that they need and that we're able to address the upstream healthcare as much as possible. Next slide. This is a map of where all the CCOs are within the state as of 2025. And as you can see, their CCOs cover the entirety of the state. And there's certain portions of the state, such as the Portland metro region, the Salem metro region, the southern Oregon area, Medford, Grants Pass area, where there are multiple CCOs. But otherwise, the CCO that a person will enroll in is based on their where they live. I do see that there is a quick question, so I'm going to make sure that I answer that. The question was, can I expand on the rewards CCOs are given? And how those rewards are earned. There are a variety of different ones, but generally, if CCOs meet certain quality improvement, for example, the number of people that are routinely getting appropriate care after an ED visit, or making sure that people are getting proper pediatric care. If those measures are improving and getting better, then the CCOs get certain rewards. Also, if a CCO is incentivized to invest in the community, if they're able to control costs and manage care well, there's incentives that would allow them to make investments into their local community through it. So essentially, if they're able to control costs in a way that saves a certain amount of money, that money can be reinvested in things like health programs within a community. Next slide. So beyond OHP members, next slide. OHP improves healthcare access for everyone in Oregon by supporting our providers, people that provide healthcare services, both in clinics and hospitals. So we receive reimbursement for OHP members. And OHP is often one of the primary payers in a lot of communities. For example, in Malheur County, more than half of people are enrolled in OHP, so the health services in that county really rely on OHP to ensure that their funding, as well as community health centers across our state, often will rely on Medicaid as one of the primary payers for healthcare services. And certainly, if Medicaid weren't providing those services, then it would be much more hard for them to stay in stay in business and be able to provide services within that area. I I mentioned Malheur County, and we can go to the next slide. We see that in rural parts of the state, there's much higher rates of people that are enrolled in OHP. In part, that's due to we have a significant amount of poverty in some of our rural pockets of our state. But I'll still say that in our higher income portions of our state, it's still quite a bit of folks. For example, 22% of folks are enrolled in Medicaid, or in the Portland Metro, 1 in 3 people are enrolled in Medicaid. And so it's still such a high driver of healthcare spending within the state. Next slide. Some recent changes that we've done in the Medicaid program. Next slide, is our 1115 waiver. So I mentioned at the top that generally we have to follow all federal rules related to Medicaid, but we have taken advantage of quite a number of federal waivers throughout Oregon's history. And one of which is our continuous eligibility policy. So we were the first state in the country to say that when we have to re-enroll people on a really regular basis, oftentimes people who are eligible fall off of coverage because they have to return paperwork just to prove that they are enrolled. So kind of akin to doing taxes in addition to doing taxes, doing more taxes to prove exact information that maybe the government might have somewhere else. And so how we can reduce that people losing coverage based on paperwork is one of the key goals that Oregon has had. And so we've kept children enrolled up to the age of 6. So from birth through the age of 6, without having to go through that paperwork. We know that children oftentimes are living in poverty, and that doesn't change overnight. It's very rare that somebody, particularly when they're young children in the household, are able to significantly increase their income. And then for folks over the age of 6, we keep people enrolled and check their eligibility and verify that they're still eligible every 2 years instead of every 1 year. Beginning in January, we also enhanced the number of services available to certain youth with special health care needs. So these are additional vision and dental services, and certain other services that are covered for children, but are not always covered for adults. And we know this because when somebody is just a young adult and they had been getting really high levels of care, and they haven't gotten employer-sponsored insurance yet or other forms of health coverage, that cliff of not being able to get healthcare services, it can be really disruptive for people. And so it's only available to a small number of folks, but it's additional services beyond what is covered by adult coverage in the Medicaid program. Next slide. The Oregon's Health-Related Social Needs Program is also one of the first in the country to fully launch within the entire state. And we've launched it in 3 waves. First, we launched additional climate benefits. So this is air purifiers when there's a wildfire in the area. We know that many trips to the hospital for asthma related effects can be resolved instead of ER visits by improving the air quality within a person's home. And so we can save a lot of money on those tens of thousands of dollars of ED emergency department visits by a air purifier that costs very little. The next we launched the housing benefit, which provides limited short-term transitional housing for certain individuals that meet both healthcare needs and social needs. And then finally, nutrition benefits, which were launched in January. And as there's been a lot of talk in the news recently, nutrition services are very important to maintaining people's health. And we know that if we can provide healthy food to people, we can see an improvement in healthcare as well. Next slide. And then I mentioned earlier about Healthier Oregon, which provides coverage to people who would be eligible for OHP, except for their immigration status. And approximately 100,000 people, including more than 10,000 children, have access to healthcare services due to this program. We really see this as a focus of reducing disparities within our state, because people who weren't eligible for Medicaid or healthcare services because of their immigration status often were unable to see healthcare services. And we can really see that through the services that are provided. The blue being since the launch of the Healthier Oregon program, there was quite a number of additional services that people started receiving because they were enrolled in the Healthier Oregon program. I do see, apologies for missing this earlier, a couple questions about some previous slides in the chat. Whether the waiver extended to senior populations who reside in nursing facilities. I will say that that some of the portions of the waiver, such as enrollment checks or checking on enrollment status, do apply to people who are in nursing facilities, but housing or that sort of thing is not available to people that are residing in nursing facilities. But for people that are exiting nursing facilities, they may qualify. Another question was around that the waivers will not be renewed. So the administration has let states know that a number of specific things within 1115 waivers are not the direction that the administration is planning on taking. One of which is the continuous coverage policies, the continuous coverage for people between the age of 0 to 6 and 2 years for everyone over the age of 6. They've said that that is not something that they are looking to renew in upcoming waivers. But that's still a question that we'll have, and a conversation we'll continue to have with the federal government. In terms of a lot of other things that are part of our waiver, and including the health-related social needs, there hasn't been that same direction. So in 2027, we will be having more conversations with our federal partners as our waiver is set for renewal, and about how we can design a waiver renewal that's specific to Oregon. But I'm hopeful that we can prove that many of our programs are working to improve health, and make a good case for them to be continued. Next slide. So this is a quote from a Healthier Oregon member, it is helping me continue living. And with its help, I'm able to manage my disease. So just want to note that everything that we do within the OHP team, within the Medicaid team, is focused on the people that we serve, the 1.4 million people that we are working for, who receive Medicaid benefits and OHP benefits, and really want to focus on that as our primary focus here, the experience of our members. Next slide. OHP Bridge. So this is that program I mentioned earlier for people with a little bit higher income. We had over 35,000 people as of a recent count enrolled in the OHP Bridge program. Generally an adult aged 19 to 64 who has income less than 200% of poverty level, but more than the Medicaid, what Medicaid currently covers, or OHP currently covered. They don't have access to other health insurance through a different means. We're the third state to launch this type of program. Our colleagues in DC may quibble with that a little bit because they have also begun the process of launching this, but we were still before they were, but now there are 4 of us, New York and Minnesota as well. Next slide. So some of the positive outcomes of what we've done recently is expanded eligibility for all people in Oregon, regardless of immigration status, with incomes between 133 and 200% of the poverty level, reduced people churning off of benefits due to only paperwork reasons. We kept more people covered at the end of the public health emergency than nearly any other state, and we did so without requiring people to come back to us, because we used computers and data systems in order to verify people, rather than making people come into offices or finding a stamp and returning mail to us, which is what a lot of other states relied on. We increased access to preventative services such as vaccinations, as screenings for cancer, doing all sorts of things to really make sure that we're addressing health needs as early as possible, so that we're able to have as large of an impact on a person's health as possible. We provided culturally appropriate services, both in office and through telehealth, to reach parts of our state where a lot of people haven't been able to access services before. And then we reduced insurance coverage disparities. And this is a really important note here, is that we were able to move the dial statewide, but also in a lot of groups that has historically not been covered at very high rates. We still have a lot of work to do, particularly in some of our populations that are still seeing a disparity in terms of healthcare coverage. But we've moved quite a bit over the last several years to reduce that disparity. Next slide. So House Resolution 1, which is a new law passed by the government, federal government, and signed into law on July 4th of this year, is going to present a really significant change to both Medicaid and Marketplace. So it adds work requirements for about half of our members who are enrolled in OHP. So that means that somebody is either going to be required to work, or to prove that they are working, or participating in community engagement related activities such as volunteering, or that they meet some of the exemptions from that. It will also add more frequent renewal periods, so that people have to do that activity of doing their taxes on a much more frequent basis. These changes aren't going to happen immediately. There's what we're doing right now is to work really hard to ensure that we are doing that, figuring all of that out, and um, and trying to figure out as much as we can how much information is available through IT systems. So no, we're not relying on people to fill out paperwork and send us information as much as possible. There's also a one-time 5-year rural health transformation fund. This is not intended to offset the significant amount of Medicaid cuts that will particularly affect rural communities. It is only a fraction of the amount of funds that will see reduced due to some of these policies. And the state has submitted an application that is currently under review by the federal government for a rural health transformation grant. And some of the areas that we focused on in that is improving the workforce in rural communities, improving access to services, whether that be mobile services, telehealth, and getting people access to care who are living in rural communities. And better utilizing technology as much as we can. So there is also a question about federal matching and immigration. I'll note that for a number of people with immigration statuses, the federal government largely doesn't provide federal funds for people with certain immigration statuses. And so that's why we have the Healthier Oregon program that provides 100% state funds. The federal government does pay for emergency department services because it's to prevent people from having to prove their immigration status when they're having an emergency. And that is one thing that we do receive federal funds for people that don't have certain immigration statuses that would qualify for them for Medicaid. Great. All right. Well, I think I've been talking for more than 45 minutes, in which case I'm going to drink some water and see the chat. If you have any questions, we have such a large group, so it might be easiest to ask them in the chat. I tried to take as many questions as I could, but Heather, I see you came off mute.
Yeah, thank you, Director Sando. I was gonna make the same suggestion, please. We like to keep record of everyone's questions on the Medicaid Advisory Committee. And so if you can please put your question in the chat, and I will ask staff if perhaps we could then send out there's some way that we can support Emma in responding to those questions as we're getting close to time. But there's a few, if you want to go through I can go through we have what, 5 minutes here, Emma, is that about right?
Yeah.
So I think the first one I saw on the top of the list up here was related to folks in nursing homes and if they're included or if they would be included later.
I think I answered that one. I think
Okay, you did get to
ones
that one.
that I haven't answered is starting at 9:55 on EMTALA.
Oh, okay, great. I've got that list. Okay, so and I think okay, so we have, and you did address the HRSN, so thank you on that. And there is a question about rural health transformation and the potential impacts. Ooh, that's a big question. There was many good things asked for. I don't know if you want to tackle.
Yeah, I think more to come once we find out what was funded by the federal government. Theoretically, if we meet all the criteria, which we believe we did, the federal government is supposed to provide 50% of the total amount the state can get, which is or $100 million and a year, and then there's additional money a state can get on top of that if their ideas are things that the federal government deems worthy of funding. So more to come once we see what the federal government does end up providing us. But we did submit the application and included things like workforce, telehealth improvements, and other access to care improvements.
And I do see, oh, thank you. And I do see the next question. And I think a lot of people have some confusion about this, and I'm not exactly sure if the way I'm going to interpret this question is exactly what the person was asking, RJ. But I see a question about the intricacies of FMAP and funds used for individuals who are immigrants. And I know that folks have a lot of confusion about which money goes where and how do we fund these services and how will these services be impacted by HR 1. So I kind of leave it to you to maybe provide a 101 on how that is structured and to give people kind of a foundation.
Yeah. So as I was saying, the federal government does provide emergency Medicaid services, funded by the federal government for people who would otherwise qualify for Medicaid, but for their immigration status not meeting those Medicaid criteria. And the federal government is doing a couple things as a result of HR 1. One is if somebody would have qualified for what is known as the Medicaid Expansion ACA group, we could have received 90% of the cost of their emergency department visit paid for by the federal government. Um, uh, that is changing, so that instead of 90%, it's closer to 60% of the cost. So say the emergency visit costs $10,000. Before we would only have to pay $1,000 and the federal government would pay $9,000. As of that change, the federal government will pay $6,000 and the state will have to pick up $4,000. So greater burden for the state finances, because the federal government will be paying less for certain individuals who use emergency services. And then also previously certain refugees were counted as eligible for Medicaid due to their refugee status. And the federal government changed that definition for certain refugees so that they are no longer considered Medicaid members. And so the state would pay for the full cost of those individuals.
Well, I do see we're a minute till, and I see many more excellent questions. So Sarah, I think we'll have a way to collect those and get those to Director Sando. Does that sound appropriate?
Sure.
Visual practice. Okay, great. And then we will figure out how we will share those out in our normal Medicaid advisory committee capacities, which usually means they end up getting posted on the webpage.
Yeah, and I think a lot of these questions are 201 or 401 rather than Medicaid 101 questions. So you all are very, very smart and have a lot of really great questions. And I really appreciate you all. But definitely encourage you all to attend the MAC where we dig into some of these more complex issues.
Thank you so much, Director Sando. We really appreciate your expertise and your presentation skills and your approachable nature. Thank you for making this really easy to understand and being such a, sharing your wisdom. You really have a lot of great experience, so we really appreciate it.
Of course, happy to. Have a wonderful Wednesday, everyone.